everyone, I'm Philip James, and joined here today by Dr. Rangel from Brazil. Dr.
Leo,
Will,
please.
Leo. Yeah, just to clarify, because for people watching in the US right now, they say Dr. Rangel.
Yeah. Rangel. Rangel. Anyway.
Rangel. So for those watching, it's Rangel. But for this interview, we're saying Leo. Leo, welcome. Thank you for being here. It's really an honor to have you on the broadcast. You are a pioneer, really, in RFA, and for the topic today, which is treating malignant thyroid nodules without surgery with RFA. It's a hot topic, and you're really leading the way. So, yeah, thank you for being here. And I have to ask you, is this real? Can you really treat malignant thyroid nodules with RFA?
Yeah, thank you, Philip. It's a pleasure to be here. It's a famous thyroid talk. Thank you. Yeah, now we are treating malignant nodules with radiofrequency. Radiofrequency as a whole, thermal ablation, when we talk about all the technology that we can treat those nodules, are over there since 2006-05, and I've been performing this procedure since 2016 here in Brazil, in Rio de Janeiro. So it is something that we are really experiencing. The treatment of those malignant nodules are really something that we are really discussing, and the medical community are really looking into this right now.
Yeah, for those watching in the US, this technology, they're thinking it's the latest innovation, right? That they're really only hearing about it in the last 12 months or so. But in fact, in Brazil, you've been treating patients since 2016.
Yeah.
Radiofrequency.
Yeah, we started with those benign nodules, and now it's very well accepted and established. And now we are start to see those patients with small papillary carcinomas below 1 centimeters.
And it looks like people are tuning in from, looks like we have Colombia and Honduras. Welcome to those of you tuning in from around the world. We see your questions there. We're going to try to get to them. This is a shorter broadcast, so if we don't address them live here, they'll be addressed in the comments by Leo immediately following this broadcast. But we see you there, and go ahead. Where are you from? Where's everyone from? Looks like Mexico, and great to see you there. So we'll be checking. We'll be checking questions. We're talking about really a big paradigm shift for how to treat some thyroid cancers. Now, no matter what industry it is, when there's such a big paradigm shift, there's going to be resistance. What are some of the main objections you hear in the medical community to treating malignant thyroid nodules with RFA?
Yeah, radiofrequency, I think it's in most places in such a early start that really doctors are not really complaining a lot about this. They are more, they refrain a little bit more about those new endoscopic approaches for thyroid, because they think that thyroidectomy is still the big thing for treatment. So they try to limit the endoscopic and robotic approaches, but they do not see the train that radio frequency is moving forward. I think it's when you talk about technology is when you see the remember MySpace back in the day, and they didn't see Facebook coming in. So it's something like this. So radio frequency is going to take a big chunk of the number of procedures done. So radio frequency is something that people do not really understand, because it's, as you said, it's such a paradigm shift that we face now, that people sometimes don't even understand how it really impacts. But one thing that people really are concerned about is the producing some scar and adhesion to other structures. This is not the case even for benign nodules, that sometimes we treat larger nodules, and sometimes you have to operate on those patients because of another nodule, something like this. But for those small cancers that we are not treating, those small cancers close to the trachea, close to the nerve, if you have some adhesion, you're going to have it over the capsule, anteriorly or laterally. There are some places that we can surgically address very safely. So I don't see as a surgeon having that much difficulty doing a surgery if you have to operate on those patients afterwards. But it's a personal thing. But I think it's the only thing that people can argue about the problem of radio frequency, because we are not harming the patient. And for example, if you treat a patient, let's think about the worst case scenario. For example, if you treat a patient with a micropapillary carcinoma, in the long run, they develop a metastatic lesion. For example, they have a lymph node. Okay, it's a bummer. It can happen. Then you proceed to a thyroidectomy. And you remove those lymph nodes. What harm did it do to the patient? No, you did the same surgery that you would do before, or even better, you would do just one surgery, because if you did the surgery at first hand, you would only do the thyroidectomy. Then you have to go back and do the lymph node dissection. So this time you're going to do just one surgery instead of doing two. Well, we do not have this right now, the role of each procedure at this time, and the cost benefit of each one. But there is clearly some advantages of both approaches. So.
And then from a patient's perspective, I mean, I can share that. I did have a thyroidectomy that didn't turn out well, paralyzed vocal cord, parathyroid damage. So for me, without diving deeper into the resistance, I can just say is an advocate for patients to have the RFA, avoid surgery at all costs. And because surgery, even with the best surgeon, there is risk. And with not the best surgeon, there's a lot of risk. So I think it's just a better treatment option. We had Dr. Michael Tuttle on recently, and I think it's so important with what you're saying, that how this is going to benefit so many patients. Now, some patients get diagnosed with thyroid cancer and they're okay doing active observation, active surveillance. Others hear the word cancer and it's panic time. Get it out of my body. And this is where I think what we're discussing now, today, is so powerful.
Definitely. Yeah. And one question that most doctors ask me about this, most of our guidelines do not encourage biopsies of these specific kind of tumors that we are talking here, below 1 centimeters. But as the guidelines do not address this, or do not encourage the biopsies of the smaller nodules, as the ultrasound improves and you find those nodules, we, the physicians, have to be really ethical and open with our patients and say to them, well, your nodule is not a nodule that our guidelines, most of guidelines, not encourage the biopsy. Right. But the ultrasound features are of a malignant lesion. Would you like to follow your nodule and see what happens if it increases, or do you want to biopsy? I'm really open to my patients, because it is something that your own sound mind say, oh, this is not a nodule to biopsy. But if you think it is a malignant nodule, we will have to share with your patient. And then you openly discuss it. If you need a biopsy or want a biopsy, and that's when you come to a conclusion that if the patient wants a biopsy and it comes out a malignant lesion, what do you do? So now we have options. And I think that having to be clear with the patient and doing a very open discussion about the options and having the patient clear. For example, I want to treat all kinds of patients, so I do radio frequency, I do scarless surgery, endoscopic surgery, and I do conventional surgery. So either way, we have to address the patient's demands and tackle their specific problem. For example, there are some nodules, malignant nodules, that are not amenable for radio frequency due to position, size, or something like this. So surgery is still the best treatment for that specific patient. But we are talking about a problem that is overwhelmingly diffused about in the society. So there is a very significant role for radio frequency in the treatment. So it is something that we have to discuss, definitely.
So Leo, then you tell a patient they have a malignant thyroid nodule. And previously, I mean, going back a ways, the option was surgery, or in some cases, active surveillance. But now there's a third option, and that is RFA. How are patients responding when you provide them with three options?
Well, our meetings now with the patients definitely got longer, because with a lot of options comes a lot of questions and a lot of doubts. But it is kind of interesting to explain those to the patients. So now when I face a patient, let's imagine like a small malignant nodule, that we can offer all options. I write to the patients. Now I have a drawing notebook, so I can, like for sketching, that I draw all the options and write for the patients. And actually, I hand over those piece of papers, so they can sometimes look at home and think better and come later and decide. Because as we have a lot of options, people really get confused. But the thing that really comes to the attention to the patient when we're talking about radio frequency is that we do a minimum invasive local anesthesia out of a hospital, so we can discharge the patient at the same day, and we do not risk the chances of hypothyroidism. So something that we keep the thyroid function. So this is something that is really important for patients. Generally, doctors underestimate the problem of taking levothyroxine, the replacement of those thyroid hormones. But it is something that really calls attention to the patients.
Yeah, let's talk about that for a moment, just the long-term effects of a thyroidectomy. And a lot of patients are told, and a lot of patients think maybe that they have a thyroidectomy, and they're told that you take the pill and every morning and life is normal. But often a patient isn't aware of, one, what could go wrong during surgery, even though they're told it's a low-risk surgery. And two, really, there are long-term consequences when the patient no longer has a thyroid. I mean, I could speak from experience. So can you elaborate on this topic a little further? You talked about hypothyroidism symptoms. post-thyroidectomy. How does that affect patients' lives?
Yeah, that is something that we commonly take for granted, and patients really, when we take the time and we talk to the patients, they really come with that. So as you experience it, voice changes, something like this is really something that patients can really experience with after surgery. And as we really look for, because sometimes even the vocal cords are working, but the fine-tuning of the voice, when the patient really demands, like a singer, a professor, a minister, a church, something like this, they really demand on the voice. Sometimes we find some differences if you are really thorough with this kind of research. But we are talking about a safe surgery. We are talking about something that we do not want to get people afraid, but there are some limitations. It is a big surgery, and we can take care of huge tumors with the surgery. And sometimes I think we have to adjust the size of our hammer to the problem. There is a really good sentence that I use a lot in my lectures. That is, if you only have if you only have a hammer, all your problems are nails. So if the problem is big, you take a big hammer. If the problem is small, you take a small hammer or another device. So that is something that we can really see in the future. So we are adjusting the treatment to the problem of the patients. Because back in the 80s, for example, we used to do total thyroidectomies for small cancers, large cancers, metastatic cancers. Was all in one basket. Now we have different thyroidectomies. We have robotic thyroidectomies, endoscopic thyroidectomies, lobectomies, total thyroidectomies. So, and now radio frequency, inactive surveillance. So there is something new in our field. So we have to really understand which role each kind of treatment has in each patient. So the selection, I think it's what is going to change really, what is going to really change in our management.
Well, what you're saying is catching a lot of interest. We're seeing some comments here come in, and for those of you asking questions, we're going to get to those shortly.
Please.
Looks like some questions from El Salvador, Guatemala, Mexico, Colombia. So we see you there, and we're going to either get to those here in a moment or immediately following this broadcast in the comments. Leo, so what profile of malignant thyroid cancer can be treated or should be treated with RFA? I mean, if there's metastasis, can it be used? In what cases should it be used? And in which cases should it not be used?
Yeah, we just had a webinar on that for doctors, and we're just talking about anatomic factors, and we have patient factors like anxiety issues, anatomic issues, for example, the neck extensions. Sometimes not possible to do the safe radiofrequency ablation, but the most variable thing is the tumor factors. For example, of course, we have those really low risk cancers. They are the majority. They are the overwhelming majority of those cancers. But how do we know that we are not treating one of those bad cancers? That's the key thing. So we have to be sure that we are treating those we are treating one of those nice ones. So we have to really address the neck, look for lymph node metastasis. The biopsy should be really a good one. We should confirm that is a malignant nodule and not for example, medullary cancer or a plastic cancer, something like this. And then when we really select the tumor type, we are going to look for the position. So the thyroid, although it's small inside the neck, the nodule is even smaller. So the nodule can be over the capsule, closer to the skin, or it can be abutting the trachea or close to the recurrent laryngeal nerve. In those cases, last cases, surgery is safer, because we do not want to risk the chances of damaging the nerve or close to trachea, have a major complication. So we would address through surgery. But most cases, as the nodule is small, we can address even close to the carotid, or we can separate those structures during the procedure and do a safe procedure. So there are a lot of cases that we can do. But not all cases. So it's not a.
Yeah, there's some patients listening that already had a. Oh, go ahead.
It's not a one shoe fits all. So
yeah,
you have to.
And there's some patients tuning in that already had a thyroidectomy, and they're thinking, "Darn it, where was this technology? Back when I had a thyroidectomy."
Yeah, I got this a lot. So thanks to you, we should have more patients involved in this.
Yeah. So profile of patients. Has it happened before where you tell one of your patients that, in fact, they're a good candidate for RFA, and then they still opt for a surgery?
Yeah.
What's the psychology behind that?
Well, each one has its own background. So I even got one patient for it was a benign nodule. I was offering for a radiofrequency for a benign nodule, and she came out with an undetermined nodule, but it was so benign on the ultrasound. So I asked her for another biopsy, and it came out benign. So thumbs up. So it's a benign nodule. Let's do radiofrequency. And the girl said, "No, doctor. My mother died of cancer. My father has cancer. My dog has cancer. Everyone I know has cancer. I cannot have this. Remove this." So I understand everyone has its own background. So I do not judge. And we have to offer the options. And especially when we talk about the Latins, the South Americans, and all the Latin background people, they experience this cancer thing different from the Americans and the Northerns. They do not face, and they not take this well, the cancer thing. So for example, active surveillance in Brazil. Not a lot of people are doing this. Not a small number of patients are following this. We're not Japanese that can follow and take care of this. Brazilians really feel that they have to do something about the cancer. So that is the general feeling.
Leo, as we kind of get close to the end of this interview, just some rapid fire questions that probably, I see some questions coming in right now. Does it hurt? Does radiofrequency hurt?
No, not at all. It's just a little bit over what is a fine needle aspiration is.
How long does the procedure take?
Roughly 15 minutes.
How much does the procedure cost?
Yeah, it depends really on the area that we are talking about. But in Brazil, some insurances are already paying for it, so they got all reimbursements. Some insurances they are not legally obliged, so sometimes the patient have to purchase the needle and in order to do the procedure, and the medical team, the insurance covers. So the needle here in Brazil costs around $1,000 to $1,500 US.
And let me tell you, as a patient that lost a thyroid and things didn't turn out too well afterwards, that is really inexpensive, an inexpensive price to save your thyroid. Okay, so a few questions here to patients asking where they can find a doctor who treats thyroid nodules with the RFA. Where can you send patients to find an RFA doctor?
Yeah, there are a lot of new initiatives. So we have this really nice website, rfamd.com, that gathers doctors from all over the world. So I guess it is very interesting to find the closest to you, rfamd.com.
Great, we'll put the link to that resource in the comments and also in the episode details. Thank you, Leo. Thank you so much for your time today.
No, don't mention. Farewell. It's a pleasure to be here. Thank you, guys.
See you, everybody. Thanks for joining us.
Thank you.